the medical field, radical prostatectomy is a standard treatment for men with prostate cancer. But unfortunately, 1/3 of patients with prostate cancer will face a relapse. And this relapse is usually seen by an increase in PSA. So it's a biochemical relapse. And usually these men are those who have high-risk features, like seminal vesicle invasion, like T3 tumors, high Gleason score, extracapsular extension. And for these men, 3 previous randomized trials showed that actually immediate adjuvant irradiation was of benefit in terms of biochemical control, in terms of local control, and in one of those trials also in overall survival. There were like 2 schools in oncology. Those that would support the use of immediate adjuvant irradiation and those that would say, no, we need to wait, but wait until when? From radicals, it becomes evident now, and after having recruited more than 1,300 patients, so it's a trial that is well powered to detect this, that there is no difference in biochemical relapse if we actually wait for administering radiotherapy in the early salvage setting. So they have included men with intermediate high risk because they actually had one adverse prognostic factor like T3, high Gleason score, or high PSA. To me, these men represent my clinical practice, so for me this trial was extremely important to see. What we could see today is that actually the investigators from the 3 randomized trials got into an agreement for the artistic meta-analysis. So this meta-analysis presented by Valet and colleagues actually shows the same results. When the 3 trials looked into biochemical relapse, there is absolutely no difference, and actually the hazard ratio points in a little bit better way for early salvage irradiation and not for adjuvant. So meaning that if we wait until PSA is no more than 0.2, and this is important, then we are sparing a lot of men from actually side effects from radiotherapy. And this is extremely important because these patients are recovering from surgery. So surgery is already causing a lot of side effects. I think as soon as the patient that you have represents the patients in the trial, so having one adverse risk factor, then I think we need to offer early salvage irradiation. We cannot wait anymore. Some people were waiting for a PET PSMA to show where the lesion is located, and then the PSA would be more than 0.5. That's not an option anymore. But it's not an option anymore to deliver adjuvant irradiation to everybody. Although I think we still need to consider maybe and discuss with the patients immediate adjuvant irradiation for those patients that are very young. They have several risk factors that get concomitantly together in the pathology specimen.